All right, so I have no disclosures. So let me start with a patient story. And this kind of story is very common in my clinical practice. So until my diagnosis, there were no less than 13 doctors who could have taken detailed family history from the members of my family and referred them for genetic testing. It never occurred prior to the time I was diagnosed with a cancer. And some could argue, does this qualify as genetic malpractice? So with that, my objectives today are to talk to you about some primer to genetic testing and genetic counseling. And I promise to keep this talk very practical. We'll talk a little bit about universal tumor testing, and then we will go over some criteria that you can use in your clinical practice to define criteria for referral for genetic testing. So let me start with a question. How common do you think is Lynch syndrome in the general population? 1 in 300, 1 in 1,000, 1 in 5,000, or 10,000? Any guesses? Yes, 1 in 300. It's very common as many BRCA mutations. So it's very likely all of you have taken care of Lynch patient, but they did not know their diagnosis. It's estimated that more than 90% of Lynch patients are not aware of their diagnosis. But with technological advances and acceptance of genetic testing by the consumers, this is likely to change. So let's talk about genes associated with colorectal cancer. So it depends on what age group you are looking at. So for the older cohort of patients 50 years and above, about 10% of colon cancer is due to some genetic syndrome. In that, of course, Lynch syndrome is the commonest, about 3%. If you look at the younger cohort of 35 years and younger, about 30% of those patients have some kind of genetic mutations, germline pathogenic variants, and about 23% of those are Lynch syndrome. So if you look at the table in the bottom, it lists some of the commonest genes associated with colorectal cancer. They are Lynch genes, MLH1, MSH2, MSH6, PMS2, polyposis genes, and the pink ones are lesser common other genes as well. So a word about Lynch syndrome. It's due to mutation in mismatch repair genes. And risk of colorectal cancer, it's not the same for every single Lynch person. It depends on the type of their mutation and also growing evidence that other risk factors. How strong is their family history? Somebody with 10 colon cancers with a given mutation is a different person versus fewer cancers in their family. And with time, we will learn about individualized risk factors and recommendations for Lynch patients. Latest practice change came from NCCN, where they recommend the age to start colorectal cancer screening for MSH6 and PMS2 is about 30 to 35 years, unless they have very young age colon cancer in family. And it's 20 to 25 for MLH1 and MSH2 patients. And it should be repeated every 1 to 2 years. So some basics of somatic and germline mutation. As many of you may be familiar, a somatic mutation is a mutation in a somatic tissue. So for example, we know all cancers are due to some mutation. So somatic mutation in a breast tissue in this person will cause breast cancer, but it would not be heritable. In contrast, a germline mutation will be present in egg or sperm, and that will cause this mutation to be present in every single cell of the offspring, and then they will pass it on to their offsprings as well. So let's talk about universal tumor testing for colorectal cancer. What is it? It's simply any single colon cancer specimen that goes to your pathologist, automatically they would run immunohistochemistry, IHC, or microsatellite instability, MSI testing. It does not require any special consent from your patient. You may see this popping up as an addendum to your colon cancer specimen pathology results. So microsatellite instability. So microsatellites are stretches of DNA with repetitive sequences of nucleotides. So it could be multiple A's or CG here as an example. And when mismatch repair genes are mutated, the correction of this spell check, that's broken. And that can result in microsatellite unstable tumor. So a take home here is, if you see a colon cancer specimen resulted as microsatellite unstable, or also known as MSI high, all of them, it's not confirmatory of Lynch because it raises suspicion for Lynch. Sporadic tumors can also be MSI high. So switching to IHC or immunohistochemistry, what is it? So here you can see in the cartoon, a normal gene results in normal protein, and a mutated gene would result in abnormal protein or absent. So for IHC, antibodies are used to stain for these mismatch repair proteins. If the gene is mutated, the protein would be altered and the staining would be absent. So you may see this pathology result addendum for immunohistochemistry. The green box shows you a normal IHC. That's what you want to see. It is resulted as immunohistochemistry IHC being normal, or also the other terminology is MMR proficient. That means all of these mismatch repair proteins, they are listed, I have seen in some reports, as present or IHC positive. So positive here is actually normal. That's what you want to see. In contrast, the red boxes show IHC abnormal or DMMR, standing for deficient mismatch repair proteins. And it can show as MLH1, PMS2, or any of these, one or multiple being absent. So take home here is, any abnormal IHC finding, especially if that includes MLH1, does not necessarily confirm Lynch syndrome, because there could be MLH1 promoter methylation, which is epigenetic change with methylation of MLH1 promoter, and that happens in sporadic tumors. So this is a nice clinical decision support tool that you can use. I don't have a cursor here to walk you through, but any colon cancer tumor tissue as part of universal tumor testing undergoes IHC and or MSI. If MSI is high, germline testing for Lynch syndrome should be done. If IHC, in IHC, if MLH1 is missing, those patients should undergo MLH1 promoter methylation testing or BRAF testing to make sure they are not sporadic tumors. If it's sporadic, Lynch testing, germline is not necessary. In other cases, germline testing for Lynch for confirmation should be done. Okay, so going back to some more basics of, a fellow once told me a diagram with circles and squares. This is called pedigree. This is drawn by the genetic counselors during patients' genetic counseling visit. And I find it very helpful in my clinical practice, especially if patients have multiple family members with multiple cancers. The color coding, it can be very helpful to take a quick look. So just a refresher again that the arrow proband is the person you are interested in, is your patient. Number ones here show first degree relatives, and those are parents, siblings, or children. And second degree relatives are uncles, aunts, nephews, nieces, and grandparents on either side. And third degree are further distant relatives. And this is important to remember when you're trying to interpret NCCN criteria to pick which patients should be referred for germline testing. So now this brings to the important question we are trying to address today. So no matter what kind of practice setting you are, you would have patients reporting family history of different cancers. And when can you think about making a referral for genetic testing and counseling? Some straightforward ones are if they have 10 or more adenoma in their colon. And for hematoma, just two hematoma qualifies for referral for genetic testing and counseling. The other criteria include tumor testing with mismatch repair deficiency that we talked about, or patients with family history of known genetic syndrome. So somebody has any family member with Lynch, they should be tested. And the other criteria are meeting NCCN criteria for Lynch testing or a PREM score of 2.5 or above. We'll talk more about that. So a take home is a PREM 5 model. It can be used in any busy clinical setting. I often encourage my fellows to use it. You may be seeing IBS patients, IBD patients. If they say they have this family history, quickly Google PREM 5 and this link will pop up from Dana-Farber. Easy calculator, very easy questions. They'll ask about patient's age, gender, family history. And here is a screenshot to show you how this looks like. It very quickly spits out a score and also guides you that, yes, this patient has high-risk family history, consider referral to genetic counseling and testing. So this is one easy way to use. What's the other option? The other option is using latest NCCN criteria for Lynch syndrome testing. It can be a little bit complicated, but you'll get used to it. So I'm not going to read all of these, but they include if you have a patient with one first-degree relative with a colon cancer or endometrial cancer diagnosed age less than 50. So what does it mean? You're going to scope somebody, and they end up sharing that their sister was just diagnosed with colon cancer at age 45. And that history is enough for you to make the referral for that given person for genetic testing, assuming the sister who had cancer did not get genetic testing, not accessible or not possible. So knowing that criteria, it doesn't need a lot of cancers. Certain young age cancers do qualify. And there are other criteria with second degree and other first degree relatives listed here. I would like to point out here that what does it mean to have Lynch syndrome related cancers? So it's listed here in the bottom. Here you can see glioblastoma, small bowel cancer, stomach, pancreas, and several other are known as Lynch syndrome related cancer. And how does that translate to clinical practice? So let's use criteria, the last one that says 3 or more first degree or second degree relatives with Lynch syndrome related cancer, regardless of age. So it can translate as a person you see again for routine screening endoscopy, and they end up sharing that their maternal aunt, maternal uncle, and maternal grandma. So these are all second degree relatives. They have to be on the same side. It can't be counting paternal on this side, maternal on other side. And if they had one had pancreas, other had endometrium, and the third one had stomach cancer, that person kind of meets this last criteria for a referral to genetic testing and counseling, regardless of their age of diagnosis. And here in that example, as you noticed, I did not say colon cancer because multiple Lynch syndrome related cancers also qualifies for referral for genetic testing. All right, so that's for colon cancer. Now let's switch to pancreatic cancer. So 10% of pancreas cancers are due to genetic causes. And the genes commonly associated are listed here: ATM, BRCA, CDKN2A, Lynch genes, PALB2, STK11, and a few others as well. So in your clinical practice, when do you think about, your patient mentions a family history of pancreas cancer, when should you start thinking about making a referral for germline genetic testing on them? I find this algorithm to be very helpful. So let's go over this. So if any person with a diagnosis of exocrine pancreas cancer, listed here as PDAC, pancreatic ductal adenocarcinoma, regardless of their age, no matter what their age is, if you have a diagnosis of PDAC, you should get germline testing. Easy. Let's say if your patient is the one who does not have pancreas cancer, but they end up sharing that their mom or dad or a sibling died of pancreas cancer at any age, but they can't be, they can't be reached or they can't undergo genetic testing. In that case, your patient meets criteria for referral for genetic testing and counseling. And the third one in the bottom is patients with known family history of genetic syndrome. That's easy. Of course, they should get tested for any pathogenic variants. And in my, today you would see me saying pathogenic variant or mutation interchangeably. Just a reminder that the newer, more acceptable term is pathogenic variant. Mutation is not favored anymore. I think it's kind of complicated to tell somebody they are mutant, aliens. So pathogenic variant is a newer term. All right, so what happens if you do germline testing and that's negative? The story doesn't end there. So let's talk about what is familial pancreatic cancer kindred. So I made an example here, and I'm sorry there's no cursor, but I'll walk you through. So if you look at the arrow, let's say this is Miss Jones, a 52-year-old patient comes for a screening colonoscopy by Dr. Lee. And while he is sedating her, she is relaxed with Versed, and she shares that, oh, my mom died of pancreatic cancer at age 72. And then while she is about to doze off, she also shares that her maternal grandma also died of pancreatic cancer at age 67, old age. So now you have decided that she meets criteria for germline testing for pancreatic cancer genes. Let's say you test her and a multi-gene panel test comes back negative. What do you counsel this person? Do they have increased risk of pancreatic cancer? Should they undergo surveillance? And as we know, pancreatic cancer, most of those are diagnosed late. And if we can offer surveillance to early detection, goes without saying, is critical. So yes, this patient still warrants pancreatic cancer surveillance strategy discussion because she meets classic criteria for familial pancreatic cancer, which is 2 members being diagnosed with pancreas cancer who are first degree relative to each other. And the person whom you are counseling is first degree related to one of these 2. So that will be this family. So this particular patient, despite having a large multi-gene pancreatic cancer panel being negative, is familial pancreatic cancer kindred and should be offered pancreatic cancer surveillance with MRCP and endoscopic ultrasound starting age 50 or 10 years before the youngest age of pancreas cancer diagnosis. That will be like 50 in this person, and it should be alternated every year. So now you have identified patients with high-risk family history, made a referral for genetic counseling. What really happens when they go see them? They take, of course, extensive family history, make a pedigree, and genetic counseling and testing order does not require a counselor. It can be done by anyone. I know many providers in private practice, they have taken this on and they do counseling with some training and order genetic testing for high-risk mutations. So in genetic counseling, patients should undergo discussion for limitations of testing. There are many genes that are not known. And the other caveat is genetic testing finding can result in a VUS, variant of unknown significance, or you can have some finding of some newer genes which do not have well-defined penetrance or management strategies. So if you have a patient who likes to worry about every single finding, you may want to use a smaller panel for testing for those kind of patients. And the other discussion should include GINA. So GINA is Genetic Information Non-Discrimination Act, signed into law in 2008 by President Bush. It prohibits traditional health insurance plans from discrimination based on genetic information. But the caveat, it does not cover life insurance plans, disability insurance, long-term care. So I have had some patients, if they are about to go routine elective genetic testing, I have this discussion, and some have chosen to buy life insurance if that's part of their life goals, and then undergo genetic testing. So important discussions. All right, so after counseling, how do we order a test? Again, simple and easy. This can be done from home. A kit is mailed to, we place the order. Written consent is not necessarily required, by all labs. So some do. So then you just mail the kit to patient's house, simple instructions, and they spit in a saliva tube and mail it back to the lab. And results come back in 2 to 3 weeks. Very straightforward. Most of the time, the sample is saliva sample. You can also use cheek swab, a buccal swab, and rarely skin biopsy, fibroblast cultures. That's more for bone marrow transplant recipients. And just know that blood test can also be used for genetic testing, but saliva is more common just because it's easy. Out-of-pocket cost. So cost of genetic testing, good news. With next generation sequencing, genetic testing, a panel that used to cost several $1,000s, it could be just out-of-pocket cost, even without insurance coverage, for 100 or 150 genes could be as low as $250. Very affordable and covered by most of the insurance plans. And many companies like Apple, they offer free genetic testing for their employees, regardless of their family history. Testing results, so it can show up as positive result with mutations. So all of these terminologies in the red box mean the same, means it's positive for a mutation or pathogenic variant, likely pathogenic variant, or the older one terminologies are deleterious or suspected deleterious. So if you see any of these results in the report, they pretty much mean the same for your clinical management. Or the other thing you can see in the result is VUS, variant of unknown significance. And I see lots of confusion around that. So it simply means, there is a variant, a different code that we do not know if that causes disease or not. So in practical terms, if you see that result, that should be managed as a negative result. Over time, as we get more data, 95% plus of these variants get reclassified as benign. But a small fraction, especially in those with suggestive family history, I have seen in my practice, they get reclassified as pathogenic, and labs generally keep a way of contacting these patients and notifying. But that's, remember, is a very small fraction. So almost end of the talk. So why else timely genetic testing is critical? Because let's say you have a colon cancer person about to undergo surgery. It's a woman in her 50s, and knowing that she has Lynch syndrome can, she can choose to have oophorectomy and hysterectomy at the time of her colectomy. And also some patients may choose to have extended colectomy given high risk of metachronous cancer, not all, for Lynch syndrome. Therapeutics. So genomic instability may result in neoantigen expression and susceptibility to immunotherapy like pembrolizumab, and some of these patients can have wonderful response to immune therapy with excellent outcomes. And last but not the least, exciting human trials for Lynch syndrome are already undergoing at multiple centers in this country, so the future is bright. Here is a list of resources for you to find counselors, clinic, and NCCN is a great resource, requires a login and password, and some patient information links as well. So in conclusion, I hope I have convinced you that technological advances have made genetic testing more affordable and accessible. Timely diagnosis of genetic cancer syndromes can alter therapeutics and outcomes for the patients and also their families. And family history and referral to genetic testing should be a routine practice for all, irrespective of your practice type. And with that, I conclude my talk and really appreciate your time and attention. Happy to take any questions. Thank you.
Sorry, please put him on after.
Oh, perfect. Let's try this again. Okay, perfect. Thank you so much. Thanks, Dr. Singh. Great presentation.